Thank you, Dr. Wilson and co-chairman. We'll talk about MRI and the assessment of patients with heart failure. So I'll start out by talking about the techniques we have at our disposal using CMR, and then speak specifically about ischemic and non-ischemic cardiomyopathy and how we can use CMR to make a diagnosis and then to assess prognosis. And just to point out, in the last 2 weeks, CMR has become a Class 1B recommendation for initial evaluation of cardiomyopathy as described in the European guidelines that just came out at the ESC. So first, let's talk about the techniques we used in CMR. But most importantly, late gadolinium enhancement, or LGE, the technique that was developed in the late 1990s for detection of infarction and assessment of transmurality, such as this patient with an inferolateral subendocardial infarction. We null the signal in normal myocardium, and 10 to 15 minutes after infusing normal clinical doses of gadolinium, we see areas of bright signal within scar or fibrosis for two reasons. One is gadolinium becomes trapped in areas of collagenous scar, and because of increased volume of distribution and delayed washout. And for the first time, because of the spatial resolution of CMR, we can assess the transmurality within a segment. For example, in this segment, the transmural area is area A divided by area A plus B, or about 40% of the transmural extent of the myocardium in that segment. But in cardiomyopathies, all is not replacement fibrosis. There's interstitial fibrosis as well. The left set of panels is from a paper we wrote about 10 years ago in JACC Imaging. On the left, you see a patient with myocardial infarction. If you biopsied them, they had confluent necrosis, and you image that with by late gadolinium enhancement. The patient in panel B is a patient with hypertensive heart disease. They don't have replacement fibrosis that you can see visually with late gadolinium enhancement. But if you biopsy them, they have this lacy interstitial fibrosis. Well, now we have a technique to image that called T1 mapping and measurement of extracellular volume. And let me describe how that works. So on the top left is a normal patient. If you infuse gadolinium in a normal and image a few minutes later, there's a little bit of gadolinium in the interstitial space. In a patient with extensive interstitial fibrosis, shown as this blue lacy material, if you infuse gadolinium and image 10 or 15 minutes later, there are many more molecules of gadolinium within the interstitium because of delayed washout and increased volume of distribution. And as you know, gadolinium is a T1 shortening agent. So if you measure the T1 of the myocardium in this patient, it will be lower than in this normal. And you can use that to measure the extracellular volume by a formula involving the T1 of the blood pool before and after contrast and the T1 of the myocardium before and after contrast, and actually measure how much of the heart muscle is extracellular. Another technique to be aware of is T2 mapping. This is a patient with myocarditis. An older technique here of T2 imaging. It's hard to see, but there's a little area of bright signal in the infraseptum. But on T2 mapping, it becomes quite obvious where that area of high signal is in the midwall of the infraseptum. That's an area of myocardial edema and high T2. And it's a quantitative technique. So putting these techniques together, but first of all, measuring viability with the technique of late gadolinium enhancement. This was a seminal paper by Ray Kim and colleagues in the New England Journal in 2000, in which they imaged 50 patients before and several months after revascularization. The patient on the left had near transmural LAD territory late gadolinium enhancement. The patient in the middle had about 50% transmural late gadolinium enhancement from a circumflex territory infarct, and the patient on the right had a less than 25% transmural infarct in the RCA distribution. So how did these different infarcts fare after revascularization? Well, about 40% of the segments were dysfunctional at baseline, and most of those had areas of late gadolinium enhancement. This is an important graph on the right that demonstrates the inverse relationship between the transmural extent of myocardial enhancement with the likelihood of improved function after revascularization. If you have more than 50% transmural enhancement in a given segment, there's very low likelihood of recovery of function. If there's no enhancement, as shown on the left, there's a near 80% recovery of function with revascularization. Now, you may ask, why is it not 100%? Well, there are other reasons for dysfunction in those segments. There may be incomplete revascularization. There may be tethering to infarcted segments. And as well, it may be a mixed cardiomyopathy. There may be other reasons for dysfunction in that segment. So the recovery of function is not 100%. So here's a case of a patient with who had a STEMI 3 years previously, and you see on the cine images this thin, akinetic inferior and infralateral wall. Well, is that segment viable? Here are his vital signs. He didn't have any clinical heart failure, and here are his late gadolinium enhancement images. You see transmural enhancement of that infralateral wall near 100%. So that segment is not viable and would not recover function with revascularization, one would surmise. The real question is, does viability imaging matter in terms of predicting how the patient's going to do with revascularization? And that's an area of ongoing controversy. This meta-analysis suggests that different techniques of assessing viability, that it doesn't change outcome with revascularization. And these various techniques, the Stitch trial included dobutamine echo and nuclear techniques. The PAR2 included PET, and the most recent revived BCIS2 trial involved CMR and late gadolinium enhancement. You can see overall there was a slight trend, but really no improvement in the outcome in patients in which management was adherent to the assessment of viability before revascularization. However, it's becoming clear that the late gadolinium enhancement is quite important in predicting ventricular arrhythmias and sudden cardiac death. This is a paper in JACC a couple of years ago, nearly 1,000 patients with coronary disease, 6 years of follow-up. 3% over that 6 years had sudden cardiac death. Another 8% had ventricular arrhythmias. These investigators assessed two predictors of these arrhythmias. One was the visual extent of late gadolinium enhancement, and the second was a gray zone, this intermediate level of enhancement at the edges of myocardial infarction. And what they showed is that the combination of visual assessment of late gadolinium enhancement and the gray zone did a better job of predicting outcome than left ventricular ejection fraction. When using the standard cutoff for ICDs of 35%, greater than or less than, there was some overlap in terms of the number of events. But if you looked at the presence of both visual late gadolinium enhancement and gray zone, that together, that predicted the vast majority of events. So did better than left ventricular ejection fraction at identifying patients who had subsequent ventricular arrhythmias. This is another smaller study with the same concept from the Duke group, published over a decade ago now. And what you can see here is they split patients into 137 patients into patients who had EF greater or less than 30% and scar burden as percent of LV mass greater or equal to 5%. You can see the top two bars are the patients with the highest event rates, event being death or ICD discharge. As expected, the patients with EF less than 30% would have a high event rate. But interestingly, the patients with an EF more than 30% and scar burden more than 5% had almost a similar event rate, whereas the patients with preserved EF and a low scar burden had a very low event rate. So the presence of scar burden more than 5% of the left ventricular mass is an important predictor of ventricular arrhythmias and death. And there are ongoing larger studies to determine whether scar burden is a better predictor of ventricular arrhythmias than left ventricular ejection fraction. So moving on to non-ischemic cardiomyopathies, here's another case. Here you can see cine images of a patient with an ejection fraction of about 25%, global dysfunction. This was a 19-year-old woman who worked at a daycare center who presented in cardiogenic shock. She was begun on pressors. She had a moderate pericardial effusion that was tapped. Her vital signs were consistent with shock. She had elevated enzymes. She stabilized over a course of about 2 days, and she underwent a CMR to evaluate for myocarditis. So you see the LV dysfunction. Her late gadolinium enhancement images did not show any LGE. However, her parametric mapping, T1 mapping and T2 mapping, showed very elevated T1 values and T2 values. T1 value 200 milliseconds higher than normal, and a T2 value of 72, with our normal being less than 60 milliseconds. So myocardial edema and myocardial inflammation in the setting of severe global LV systolic dysfunction, consistent with myocarditis. I had the privilege of being part of the writing group of the rewrite of the original Lake Louise criteria that was published in JACC in 2018 to identify the way to diagnose myocarditis. So the criteria include evidence of myocardial edema, best shown by T2 mapping, but if some scanners don't have T2 mapping, and you can use the older T2 weighted imaging, but more precise to do T2 mapping, plus evidence of increased interstitial space, either shown by evidence of late gadolinium enhancement or elevated T1 or native T1. So our patient had both elevated T2 and elevated T1, myocardial edema, and increased interstitial space as evidence of myocardial inflammation. Supportive criteria include the presence of pericardial effusion and regional or global hypokinesis. Here's a third case, a 64-year-old woman who presented with heart failure, 3 months of dyspnea and edema, bibasilar rales and an S3. She had 2+ edema to her mid-shin. A coronary CTA suggested that she had normal coronaries, so this is not ischemic cardiomyopathy. And on late gadolinium enhancement, she had this interesting pattern of mid-wall stripe of late gadolinium enhancement that occurs in about 25% of patients with idiopathic dilated cardiomyopathy. It turns out scar in the heart in all causes of cardiomyopathy is a negative prognostic marker, and that's true in dilated cardiomyopathy, as shown by this study from the Royal Brompton group published in JAMA a decade ago for almost 500 patients. The presence of scar was an adverse prognostic marker no matter how you measured outcome, all-cause mortality, CV mortality or transplantation, sudden cardiac death or aborted sudden cardiac death, heart failure death, hospitalization, or transplantation. Scar in the heart is a negative adverse marker. Case 4 is a 54-year-old man with dyspnea and an abnormal echo, and you can see on his CMR he has hypertrophic cardiomyopathy with reverse septal curvature and apical form together in the same patient. CMR is the gold standard for assessment of morphology in HCM, measuring LV mass and volumes. This other advantage over echo is the ability to identify scar, as shown in this panel of 6 different patients with HCM who have different patterns and location of late gadolinium enhancement. Patient A has none, but these other 5 patients have different patterns and extent, especially patient F with this diffuse extensive late gadolinium enhancement in the markedly thickened septum. Turns out that about half to 60% of patients with HCM present with any scar at CMR. So if half the patients present with any scar, the presence of scar can't be used as a marker for ICD placement, because then you'd be placing ICDs in too many patients with HCM, over half, and the sudden cardiac death rate is less than 1% per year in HCM. So we can't use the presence of LGE as a marker, but it turns out the extent of LGE is an important marker of sudden death. This is a meta-analysis of over 3,000 patients showing that the presence of LGE is still an important marker, that there's a 1.8-fold increase in mortality, a 3-fold increase in cardiac death, a 3.4-fold increase in sudden cardiac death, and a 2.2-fold increase in heart failure death. But more importantly is the extent of LGE, as shown in this paper from Marty Marin's group. Over 1,200 patients followed for 6 years. He and his group showed that once you have late gadolinium enhancement, more than 15% of your left ventricular mass, the sudden cardiac death rate doubles. So for this reason, LGE of more than 15% of LV mass was included in the most recent 2020 ACC AHA guidelines as a 2B indication for an ICD in hypertrophic cardiomyopathy. Other findings that can be shown on CMR that are important, class 2A indications for ICD include LV apical aneurysm and a low ejection fraction or end stage HCM. So CMR is a very important exam in patients with HCM for risk stratification. I'm the co-principal investigator of a study called the Hypertrophic Cardiomyopathy Registry, or HCMR, an NHLBI supported registry that's we now recruited 2,755 patients from 44 sites in 6 countries in North America and Europe. We're at almost a mean of 7 years of follow-up, delayed somewhat by COVID, but we should be reporting on outcomes in this natural history study within the next year. But at baseline, we published this paper in JACC in 2019 describing the population. We showed that about 35 to 40% had a sarcomere mutation that could be identified. And those patients most frequently had this reverse septal curvature morphology of HCM. They were the patients with more scar, more late gadolinium enhancement, and interstitial fibrosis. But because their hypertrophy is in the mid-septum, not at the basal septum, they had very little in the way of LVOT obstruction. Another group, about another 40% of the population, had isolated basal septal hypertrophy. They were sarcomere mutation negative. They had less late gadolinium enhancement and often none, and very little interstitial fibrosis. But because their hypertrophy is at the base and the basal septum, these are the patients with extensive LVOT obstruction. So we surmise and expect to see that these are the patients on the right with heart failure, isolated basal septal hypertrophy obstruction, that may be candidates for mavacamten and other myosin inhibitors. And perhaps these patients who are sarcomere mutation positive with extensive scar are the patients at higher risk for sudden cardiac death. But further follow-up will determine that. The fifth case I'll show you is a patient with severe LV dysfunction with an unusual pattern of wall motion abnormalities that don't fit a coronary distribution. This was a 56-year-old gentleman who presented to our CCU with incessant ventricular tachycardia that quieted down on amiodarone. He had RALs and S3 and edema, and he had this interesting pattern of late gadolinium enhancement with a predilection for the basal aneuroseptum and sparing of the subendocardium, shown here in the basal aneuroseptum as well as here in the basal inferior wall. So this is not myocardial infarction, because myocardial infarctions begin in the subendocardium and transmit out to the subepicardium. This is a classic form of late gadolinium enhancement seen in myocardial sarcoidosis, which indeed was this patient's underlying diagnosis. Our group has shown in this meta-analysis of 11 studies, 805 patients, that the presence of LGE in sarcoid is a marker of adverse outcome, 6-fold increase in the combined outcome of death or ventricular arrhythmias as opposed to those without LGE, and a strong trend to an increase in all-cause mortality. So the presence of scar in sarcoid is an adverse marker. Last case is a 78-year-old gentleman with a history of carpal tunnel release. I apologize, these movies don't play, but I can tell you he had global dysfunction and EF of 30%. It appears that there's asymmetric septal hypertrophy. One might think this is HCM, however, this is an HCM mimic. He presented with heart failure, with edema. His echo and CMR suggested LVH and an EF of 30%. And these are his late gadolinium enhancement images, which is a diagnostic of myocardial amyloidosis. You can see that there's this dark signal in the blood pool. It's very hard to null the signal in normal myocardium, in the abnormal myocardium, and there's this diffuse transmural gray late gadolinium enhancement, very different from the patterns of late gadolinium enhancement I showed you in previous disease processes. There's another pattern of LGE one can see in amyloid, this diffuse subendocardial LGE, very different from the transmural LGE I showed you on the last slide. Either pattern is quite accurate against endomyocardial biopsy for the diagnosis of myocardial amyloid. Also in amyloid, as shown by the Oxford group, you can see native T1 values 200 milliseconds higher than normal, very different from patients with aortic stenosis, where there is no increase in interstitial space relative to LV mass, and the native T1 is normal. One must use pyrophosphate scanning to differentiate AL from ATTR patients once you've identified amyloid by CMR, because there's overlap in terms of the pattern of LGE between AL and ATTR amyloid. You can see in AL there's just about equal numbers of absence of LGE versus subendocardial versus the transmural pattern. In ATTR, the vast predominance is transmural, but again, there's some overlap. So the pattern of LGE cannot be used alone to differentiate the subtype, and one must turn to pyrophosphate scanning. Again, our group, led by Jonathan Pan, is imaging fellow presently, showed that the extracellular volume in amyloidosis in this meta-analysis was the most important predictor of outcome, more predictive than native T1 or the late gadolinium enhancement. So the ECV in amyloid ranges from the low 30s up to 60%, remembering that a normal extracellular volume is about 25%. So in summary, CMR has really become a crucial part of the evaluation of patients with cardiomyopathy. In ischemic cardiomyopathy, LGE and viability imaging is not clearly useful in terms of predicting outcome. However, LGE is becoming increasingly important in predicting sudden cardiac death risk, and may be more important than LV ejection fraction. In non-ischemic cardiomyopathies, T1 and T2 mapping is added to the diagnostic armamentarium, and late gadolinium enhancement combined with parametric mapping is both prognostic as well as diagnostic. And as a reminder, newly diagnosed cardiomyopathy patients should have a CMR as part of their workup, as demonstrated in the recent ESC guidelines. And with that, I'll end, and thank you for your attention. Happy to answer questions during the discussion.